Thank you, sir. Thank you for this opportunity, and thank you for creating ECNG, where we will be able to discuss issues in our day-to-day practice in a very important manner. Today, I will be discussing about a new our molecule, which is Finerenone. I'll be detailing through the mechanism of action and the earlier clinical trials, and I'll be handing over the session to Google. And also, I would like to thank Bayer for the opportunity and the uh, help in creation of the slides. We all know that urinary albumin creatinine ratio is a risk factor for cardiovascular death and all-cause mortality. We previously thought that it is at very higher levels that becomes an issue, but the studies has demonstrated that even at 30 milligram of urinary albumin creatinine ratio, there is significant risk factor. It acts as a significant risk factor for cardiovascular death. So it can also affect the CV outcome. And albuminuria is also an early marker of heart failure risk. Multiple trials has documented that increase in UACR is linked with up to 2.7 times the rise of incident HF. So this brings us to the pertaining question that are all the drivers of CVD and CKD progression are being addressed. Now, what are the drivers? There are hemodynamic, metabolic, and inflammatory drivers. This leads to CKD and CVD progression. Now, we have presently two major agents. Previously, we had two major agents to control this. One is the RASI and the SGLT2. If we analyze the major trials of RASI and the SGLT2 inhibitors, there is significant residual risk even after using these drugs. There is significant residual risk of increase in cardiovascular disease and chronic kidney disease progression. So, this leads to kidney failure and heart failure. So the aldosterone, the mineralocorticoid receptor activation by aldosterone plays an important role in the inflammation and fibrosis. So the previously available mineralocorticoid receptor antagonist, they used to work on the mineralocorticoid receptor only. Finerenone has a major advantage that Finerenone, it actually binds with the mineralocorticoid receptor, and it also blocks the recruitment and binding of transcriptional cofactors. And there is another change that is occurring. There is change in the mineralocorticoid receptor, and there will be less inflammation-driven cytokine production while we are using the mineralocorticoid receptor antagonist. So there is improvement in the hemodynamic factors, less inflammation and fibrosis, and less albuminuria with the use of Finerenone. The uh, first one, spironolactone, has very potent, but the selectivity was much less with the significant cosmetic side effects and the very high half-life of more than 20 hours. But eplerenone was the second generation agent, which was the potency was low, but the selectivity was very high and the duration was for 4 to 6 hours. Finerenone combines both these things. There is significant potency against MR and the selectivity is also high. And on the other chance, there is only short half-life, thus there is lower rates of hyperkalemia. Now, what are the evidences which support the Finerenone's cardiorenal benefits? May I have the first poll, please? Jitin? Yeah. Please tell me which of the trial gives you the maximum confidence in using Finerenone in diabetic CKD? Please end the poll and share the results. Yeah, majority has given it as a Fidelio DKD. Yeah, that is the truth only. Now, the Fidelio and Figaro has been combined into a pooled analysis, that is the Fidelity, in which there was a run-in period followed by a screening period in which the hyperkalemia risk factors were assessed, and the patients were initiated on Finerenone 10 or 20 milligram once daily, and then the median follow-up period was for 3 years. An important factor is that in this trial, there was around 40% of individuals with albuminuric CKD. They had preserved kidney function, that is group between CKD G1 and G2. If you see the baseline characteristics, the age was 67 years, HbA1c was 7.7, and the mean proteinuria was around 515 milligram per kilogram. There was 14% risk reduction in the composite CV endpoint and 23% risk reduction in the composite kidney endpoint. And Finerenone reduced USCR by 32% between baseline and fourth month versus placebo. And the decrease in USCR was maintained throughout the study period. So the Finerenone improved cardiovascular outcome versus placebo in individuals with CKD and type 2 diabetes mellitus. And it also reduced the risk of first heart failure and also reduced the risk of new onset heart failure. Now, the one major issue with Fidelity was that in the trial, there were only very few people who had use of baseline SGLT2, that is around 877 individuals compared to around 12,149 without any SGLT2 usage. But the reduction in USCR with Finerenone was seen in individuals on SGLT2 also, but we cannot draw much significant conclusions with this small sample size. Now, Finerenone has severe adverse effect compared to placebo. There was increased incidence of hyperkalemia and little bit increased almost similar incidence of AKI and very less chance of gynecomastia and unlikely to spironolactone, which can actually worsen the diabetic control. There was no significant change in HbA1c in Finerenone. But the hyperkalemia was not leading to permanent discontinuation, or hyperkalemia was not leading to death. Now, with this, there was the pillar-based management of CKD in type 2 diabetes mellitus. And the one other important thing, whether the SGLT2 and Finerenone can be initiated simultaneously, was analyzed in the confidence study, which was a randomized double-blind 3-armed parallel group phase 3 study in which the individuals were divided into 3 groups: combination, Finerenone alone, and empagliflozin alone. And the primary endpoint was at 180 days, what was the relative change in USCR, and secondary safety endpoints as EGFR changes and the adverse events. HbA1c should be less than 11, EGFR between 30 to 90, and USCR between 100 to 5000. Now, the one important thing in this study was that around 16% of the individuals were from India, around 800 in this, around 130 were from India, and the EGFR was 54 and the mean USCR was 579. So there was a representation of individuals with a significant proteinuria. Now, when we analyze the results, what we see that the combination was able to decrease USCR up to 52%, whereas it was 29% with the EMPA alone and Finerenone alone has 32%. And the combination therapy has resulted in a greater reduction of USCR. And after stopping the therapy, USCR levels increased but remained below baseline for all treatment groups. Now, 70% of patients were simultaneously initiated on Finerenone and SGLT2 had shown that there is around more than 30% reduction in USCR. ADA actually advises us to get an USCR reduction of more than 30% from the baseline, which can prevent the CKD progression. And when these drugs were initiated simultaneously, there was a reduction in the systolic blood pressure, but that returned to the baseline after stopping the therapy. The similar thing was noted with the EGFR also. Whenever there was a slight EGFR drop, but that has also came back to baseline, indicating that the changes were hemodynamic. And one important thing which was shown in this study is that in individuals who in the combination therapy, the hyperkalemia was much less in the combination therapy compared to Finerenone alone. If you see potassium more than 5.5, it is seen in 18.6% in Finerenone, whereas it was 15.3 in the combination group. Almost all places it is like that. So what has been proposed is that the SGLT2s can slightly offload the hyperkalemia risk in individuals with using Finerenone. The mechanism for this and whether this is seen has to be evaluated in further trials. There were no cases were serious, none led to hospitalization of death, the hyperkalemia, and discontinuation rates to hyperkalemia were less in all treatment groups. Now, these are trial settings. Trial settings are completely different from a real-world scenario. So let's examine a little bit of real-world evidences first. RW Fountain, that is a retrospective observational descriptive study in which there was around 700 and around 15,948 individuals with age around 70 and proteinuria around 203 milligram. There was more than 30% relative change in median UACR from baseline, and around 1.32 percentage had hyperkalemia, and 0.0 percentage, that is 0.4 percentage, that is 7 people had hyperkalemia associated hospitalization. Now, in a cardiac kidney metabolic diseases, what are the cardiorenal benefits of Finerenone? Now, there is the thing that these all diseases are overlapping: CKD, diabetes mellitus, and heart failure, and they have common risk factors such as obesity, inflammation, and vascular diseases. So, the FineHeart was an integration of the major Finerenone trials, that is the Fidelio CKD, Figaro DKD, and the FineHeart's HF trial, altogether combining around 19,000 patients. And in FineHeart, around 90% of patients had overlapping CKM conditions, with 3 CKM conditions in 12.1 percentage and 1 CKM conditions in 10.4 percentage, 2 CKM conditions in around 77.5 of percentage. Individual Finerenone trials were underpowered for CV death. FineHeart provided robust assessment of Finerenone safety and efficacy on CV death and cardiorenal outcomes. Now, the primary endpoint, CV death, was seen much less with Finerenone, and there was the kidney endpoint was also shown to be better in individuals who are on Finerenone. Now, when you analyze the side effects, there was a little bit increase in potassium, but this hyperkalemia was not leading much to treatment discontinuation or hospitalization, and there was no cases of hyperkalemia related death was recorded, and the acute kidney injury was also similar in both the groups: less chance of gynecomastia and less chance of hypotension. Now, what are the guideline recommendations based on these trials? The major guidelines such as the ESC, KDIGO, ADA all recommends us to use non-steroidal mineralocorticoid receptor antagonist in individuals with this thing, diabetes, to prevent heart failure and CKD progression. And in heart failure with preserved ejection fraction and this thing, there is also guideline recommendation for the use of non-steroidal mineralocorticoid receptor antagonists. And when we analyze the trial data, one important thing is that the event-free years, the anticipated event-free survival without heart failure, there is, when we use all the guideline-directed therapy, 3.1 years without heart failure, 2 years without all-cause death, 5 years, approximately 5 years without kidney failure, and approximately 5 years without a composite kidney outcome can be seen when all the guideline-based management was given compared to RAS inhibitor alone. Now, Finerenone is proposed as a core treatment pillar based on all the major guidelines. Can I have the second poll, Sujit? Jidin, please. Yeah. We are all worried about the potassium levels and Finerenone. And what is the potassium level would you consider withholding Finerenone? Please end the poll and share the results. Yeah. According to the trial data, that is the Fidelio CKD and the major trials with aldactone, the Finerenone has been started when the potassium is less than 5 millimeter at 5 millimole per deciliter at a dose of 10 milligram OD if the GFR is between 25 to 60 and 20 milligram OD if the GFR is more than 60. And you have to monitor serum potassium at month 1, month 4 and at 4 months intervals thereafter. If potassium is less than 4.8, increase the dose to 20 milligram. Continue treatment with Finerenone if potassium is between 4.8 to 5.5. Temporarily stop Finerenone when the potassium is more than 5.5 and restart Finerenone when the potassium levels comes to less than 5 millimeter at a dose of 10 milligram OD. However, there is some data which points that there is some permissive hyperkalemia when you use both Finerenone and ARB, and it may be continued in individuals with the newer potassium binding resins when the potassium values are between 5.5 and 6. Now, my key takeaway point in this was guidelines recommends both EGFR and UACR testing for comprehensive CKD screening. Early stage CKD management is frequently missed, but the appropriate intervention can slow and halt diseases. Despite standard RAS blockade and SGLT2 inhibitor, there is significant residual risk, and the mineralocorticoid receptor overactivation drives the inflammation and fibrosis. Finerenone targets the MR overactivation, and it effectively slows both kidney and heart disease progression. And the beneficial effects of finerenone highlights the potential for shifting the treatment strategies to a pillar-based approach in a CKM disease. With this, I conclude my presentation.